We'll start with Russell Dale, and Russell is another paediatrician. He's my boss. He's the head of the Department of Child and Adolescent Health. Is that our current name? It's changed a bit. And Russell is a professor of paediatric neurology. So he's a professor at the University of Sydney, but like many of us, based in a hospital. He's based at the Children's Hospital at Westmead, just next door. He is also an NHMRC investigator fellow, and he's really known as an international leader in his work in immunology and how that contributes to neurological disease in children. And congratulations, Russell. I saw you got a $1 million grant this week from Avant Foundation to look at the role of immunology in autism. Autism's very topical this week, but hopefully your work is more valid than that of Donald Trump. So welcome, Russ. Thank you for coming. Next, we have Associate Professor Sydney Chung. Is that how I pronounce your name? And Sydney is a head and neck and specialist plastic surgeon at the Chris O'Brien Lighthouse Centre at RPA, which some of you will know. She also works at the Melanoma Institute. She works at Royal Prince Alfred Hospital. She's an associate professor at the University of Sydney in surgery, and she's the academic head of plastic surgery at RPA. Her clinical and academic practice focuses on melanoma, on non-melanoma skin cancers, on parotid surgery, microsurgery, and fluid rejuvenation. Facial rejuvenation. Sorry. I was just thinking I might have to come and see you. Right. So welcome, Sydney. Next we have Associate Professor Rebecca Deans. She's a gynaecologist, so we're covering the whole part of the body here. She's a professor, a gynaecologist with a special interest in fertility and in paediatric and adolescent gynecology. And we really need people with that interest in the Children's Hospital, as you know. She's based at the Royal Hospital for Women, the Sydney Children's Hospital Network, Prince of Wales Private Hospital, and Life Fertility Sydney. Professor Deans is the lead researcher in a collaborative uterus transplant research project in New South Wales, and your team performed Australia's first uterus transplant. Be interested to hear about that. So welcome. And finally, we have Associate Professor Phoebe Williams. Phoebe's also a paediatrician, but an infectious disease specialist. She's an associate professor in the School of Public Health at the University of Sydney. She works as a clinician at the Sydney Children's Hospital at Randwick, which is part of our network, and in the policy group of the National Centre for Immunisation Research and Surveillance, which is based at the Children's Hospital next door. So you spend a lot of time going from one side of Sydney to the other. She completed a PhD in Oxford in the Nuffield Department of Medicine, and worked in the Oxford Tropical Medicine Network in Kenya with 4 children in tow. That's pretty impressive. She's also an NHMRC Early Career Fellow whose research is focused on antimicrobial resistance, including in children in Southeast Asia. So we have a great variety with us here tonight, and I might just start perhaps with you again, Russell, by asking me, could you tell me what sort of originally inspired you to get involved in research rather than stick to just clinical work?
Yes, be careful the words you use. So my journey, you can tell from my accent perhaps that I'm English, but I've been here for 20 years next year. So I was training at Great Ormond Street in paediatrics, and I did some paediatric neurology, and I think it inspired my interest. And that word inspired is probably important, capturing your imagination. And it can be inspired by the medicine or the patients or by the clinicians or the professors. And I was certainly inspired by that environment. It was a very research-intensive, inspiring environment. And then the next thing that really happened was, this is in the late 90s, clinical medicine then was different to how it is now. And I found that frustrating. And I hope you who practice clinical medicine will learn that being frustrated by the current status quo is not good enough. And certainly as a neurologist, pediatric neurologist, just to give you an example, one of my interests at the moment is neurodevelopmental disorders. Our current approach is somewhat basic and somewhat embarrassing. In truth, we diagnose things based on symptoms. If you just think about that, for things that affect 10% of the population and cost the nation and society a fortune, as David correctly says, this is a big problem. So that is, in a way, inspiring. It's inspiring for me to say, this is not good enough. And what can I do about it? Well, I can create research questions, try to contribute to learning, contribute to knowledge. And that's what you can do as a clinician who sees things and has some research training to actually answer questions. And that's an ongoing inspiration and an ongoing frustration that we can do better, because we're on that line of knowledge. To assume where we are now, we know it all, of course not. The best way to think about it is 100 years ago. Well, in 100 years' time, it'll be, who knows? I think we can't even imagine it. But we have to get there, and you don't get there by chance. You get there by structured learning, which is research.
And I think these guys are all entering their work in a remarkable time when we've got advances in technology and genetics, etc., which will really change clinical practice. So, Sydney, I don't want to generalise about surgeons, nor least about plastic surgeons, but not many surgeons go into a career that involves research. What inspired you?
So, I wasn't that noble. I just wanted to play the game and get onto the surgical training program. But I refused to do jobs after jobs of service that add, I think, very little ultimately to my CV. So I looked for someone who had clout at that time to try and get someone onto the surgical training program. And I knew that he was desperate for a PhD student. So I make a deal with him that if he got me on, I could be the new model of the new pathway of trying to get onto the surgical training program of doing a PhD, rather than year after year of unaccredited service registrar jobs. It's not been very successful, I have to say, in terms of having that as a pathway, unfortunately. And I share David's frustration. And if you think it takes too long in medicine, wait till you look into surgery. The average age is like between 35 and 40 these days. And I think that is not healthy, not for the health system and not for the surgeons. So initially, that was what got me. I was just playing the game. I was just doing the calculations to try to maximize the points. And I realized that, the best way is to be enrolled in a PhD. So I did that. I did the math. But when I eventually got on and continued on with my PhD, it's actually the research component that I love most, because it's the only thing that I own in my surgical practice, the knowledge, the research that I contribute, whereas the other things were just, service, we're just doing what people contribute. I need to feel that I've contributed to the knowledge and the science and the technology of my chosen field. So that's what kept me going, even like decades after I got into the surgical training program.
Rebecca, what inspired you to do some research?
So similar themes as the others, and then I think my main other additional one would be a mentor, very good mentors. So I was very fortunate to, when I did my basic O&G training at RPA hospital. In fact, I was a student here at Westmead, so I was very familiar and actually could take the M4 rather than the old-fashioned roads. But then when I did my fellowship component of O&G training, I did it in quite a niche area in the paediatric and adolescent gynaecology world, because that was where the job was. I wanted a fertility job. The jobs at RPA were taken. I was taught by people who were sitting in the roles, and you have to wait for all these things. So the the advice was, why don't you go somewhere else, get some other skills, and then the job will be here for the next year. And so I went and did paediatric adolescent gynae at the Royal, which was the arch enemy, and actually really enjoyed that, and then pursued the fertility. And the benefit of being at the Royal is it had that association with Sydney Children's Hospital, so that was nice and close, and I could pursue the dual goal. But in that time, I met my ultimate PhD supervisor and mentor and junior consultant when I was a fellow, Jason Abbott, who's really passionate about women's health and women's health research. And we are still collaborating really to this day. So I completed fellowship there, went over to Great Ormond Street as a bit of a theme, and University College Hospitals in London. In the UK, I must say one thing they do quite well, and it's perhaps the lack of the private sector, which is another big rant, but there's a draw. The cost of going through medicine, the cost of living in Sydney, that pulls a lot of very talented research clinicians out of research, actually, because it doesn't pay as well as going into private medicine. But in the UK, there's not that private sector, so I was able to work with some fantastic consultants there who really fostered and helped me to see that, designing a research question to treat a rare condition, which in paediatric and adolescent gynaecology, they're rare conditions, low numbers, and you go to fellowships where you can get a big volume through, and they're very good at centralising services in the UK. So I could do some research in not many patients, but because it was the biggest series, it had good impact, and that really sort of launched the next phase. So I came back, completed my PhD, and then continued on that path.
Thanks. Phoebe, what inspired you?
So yes, again, similar themes, but slightly different. Before I studied postgraduate medicine, I did an undergraduate degree in commerce and psychology, and within commerce I found my way into development economics, and I started to gain a real interest. I knew I wanted to hopefully do medicine postgraduate, but development economics really opened my eyes to the social determinants of health and starting to think in a public health manner. And then when I went to medical school and became a clinician, I really, and I still to this day, love nothing more than that, puzzle piece putting together of seeing a patient, especially in infectious diseases. We're often seeing the diagnostic dilemmas and being able to think about investigations and work out a diagnosis and treat that patient in front of you. But it would be very frustrating for me as a clinician to only treat the individual patient every day, 5 days a week. So a lot of the research I do is very translatable. So after COVID, for example, we saw lots of kids suddenly dying of pneumococcal disease that were much older than they usually are, and were a different, otherwise healthy population, and that drove some research into looking into what was this population of children and why were they getting so sick and dying. And we ended up doing a sort of 10-year study that has ultimately changed the pneumococcal vaccination schedule for Australia just last week. So, to go and see these kids in ICU and feel like you can't do anything because, they've already had a horrible episode of meningitis, but then know that through your research you can hopefully change things for more people, just like we've heard the incredible example that David gave, is what keeps me in it today. But then I really probably, similar to Sydney, I got more involved in research really because I probably had to early in my career. So I was one of the first ever part-time registrars at the hospital that I work at, and they employed, now most of our registrars are part-time, but they employed me sort of on a whim and said, we'll do it for a year and we'll see how it goes. And I was part-time because I had unexpectedly had triplets at the end of my internship year, so I needed to do some of my basic training part-time. And I realised that to be able to get that next contract the next year, I was always going to be going in a foot behind the others. I had all these full-time applicants that had a much better clinical experience that could go into those interviews with a stronger standing than me. So on my days at home with the kids, when they were having a nap, that's when I'd start to do some research papers, and I'd find inspiring clinician researchers at the hospital say, wow, that, oncology diagnosis was really interesting. Could we do a case series? And, clinician researchers are always keen to supervise. I'm sure everyone agrees. We're all keen to supervise inspired, students and trainees. And so I started doing papers through my basic training that way. Then I realised I wanted to do paediatric ID, and I realised that there's not really a person in Australia who can do that without a PhD. So again, I sort of had to do a PhD, but it became an amazing part of my journey and a really fantastic opportunity for our family. So yeah, it was sort of coincidental, but knowing I wanted to do that bigger picture medicine all along.
So I think it's evident that everyone takes a different path. Everyone's motivated or inspired by different things, and there's no right way to do things, and often it's serendipitous, I think. Maybe I could come to you now, Sydney, and ask you, what has been the biggest challenge or barrier in maintaining a career as a clinician-scientist, and how did you overcome the barrier?
Barriers. So time. I think so time, the balance between work-life balance, having a family, not feeling guilty of not being around enough. My daughter got into selective school like last week, I found out, but I thought it's actually more for me. The reassurance is actually more for me than for her. That, that's right. So that's time. And no doubt as a surgeon, the private practice versus research. And I think in the surgical world, unfortunately, there is still a lot of weight being put on. Success is still to a very big extent viewed. It's still to a big extent based on, how affluent you are or how much the clinical output is. And I think that is one big difference between here and, for example, somewhere like the United States, for example. I think those would be the two biggest challenges.
Rebecca.
Yeah, I think definitely juggling and being able to achieve all of those goals, because what I will often tell young ones like you coming to see me is that it's quite a lot. It's a long career, and everyone's just so desperate to get their registrar training done, tick, 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 tick the boxes ever since you were in primary school, I'm sure. And I think it's a much longer game. So it's looking really at the journey. And because I see a lot of people, and I've probably felt the same way, if you're just looking at getting to the end of your specialty, you get to the end of medicine, you get to the end of the junior years, you get to the end of your specialty, and then it's climbing another hill to do that PhD, that's... it's hard to face sometimes because you get a bit burnt out in the process. But if you can sort of take a step back, maybe play the long game, do them contemporaneously, that probably is the better way to look at it rather than being so goal-focused. Because certainly for me, I was able to write up sections of PhD whilst on maternity leave. And it took a bit longer, but ultimately you get there in the end. And I do feel, and maybe we're just a very hand-picked selected group, but there's a lot more pleasure to your job, I think, when you feel like you're fulfilling all those components. There's the components that's the inquisitory component that this is why you're all here. And then there's the part that wants you to make you a really good doctor and have that interaction with medicine and the interaction with your colleagues. I think if you channel yourself too early, there's a lot of doctors at my age, I think, who have devoted themselves just to the clinical grind, and they're a little bit disillusioned, is my feeling, and a little bit sometimes a bit jealous as they say, oh gosh, why do you get to go over to these great conferences and present this wonderful work? And it's very easy to burn out in clinical medicine because you're giving so much of yourself all the time emotionally to that individual person, whereas it gives me that balance. I don't know whether I've answered your question. I've gone off on a tangent, but I think it's maintaining that vision for the future, for your long-term career, not just the next year.
No, that's right. And when you've been working like me for 45 years in practice, you realise that there was no rush. You could have taken that year out to swan around Europe or do a language degree or whatever it might be. So that is really important. Russ, challenges and barriers, and how did you overcome them?
Yeah, like I took 6 months off. When I was 36, and it was after my PhD, and it was like you either do it now or you're not going to do it, and that was a great choice. But lots of people went, you can't do that. You can't get off the conveyor belt. Anyway, I could, and I got back on. As far as sacrifices, look, I trained in the UK. I was planning to stay in the UK. I was offered a clinical job in London, but I came to Sydney to do an academic job. That was a big call, but it was the right call because it felt that's what I wanted to do. I mean, the big challenges are the competing priorities. You know, it's the juggle, and this is a male speaking, so you can roll your eyes if you wish, and that's fine. But the competing priorities is also the good stuff. You know, you'd be really boring if you just did your job. And, you know, I've got 3 kids, and my daughter still thinks I'm great. She's only 12. It'll stop. But, you know, on a Wednesday and Friday morning, I do the top and tail of the day. My wife goes to work, so I do the school stuff. And that's the good stuff. In truth, it's like the cappuccino or the baby-chino thing. So that balance is so important, but it is hard to achieve. I'm not going to pretend it is. I think the only way to achieve that is ruthless efficiency, which taps into what David said about if you don't need to read it, if you don't need to go to that meeting, don't. You can only really afford to do that once you've earned your stripes, though, I think. You can't do that when you're beginning, because then you'll be considered arrogant. Yeah, exactly. So you can only do that after a period of time, but you can try to be as efficient as possible right the way through your career.
Thanks. Phoebe, apart from triplets, I mean, that's a definite barrier.
Yeah, challenges and barriers. Yes, so I guess we've all talked about that challenge of having competing workplaces and competing bosses that I think they all think we all work full-time for all our different roles. Sorry, not close enough. And I do work 7 days a week, but I am at a level now that I have flexibility in those 7 days. So there is no way I could be a clinical academic without working 7 days. If anyone can, I'd be impressed. But a lot of my research time happens on the weekends or in the evenings. And yesterday morning I finished a meeting with the WHO at 3 a.m. But on Friday morning I'll be at my son's school watching him do the Book Week parade. And this morning I could take my other son with a sore tooth to the dentist. So I see that flexibility that being a clinician researcher gives you. Yes, there's always a bunch of papers that need your revision. There's the journal articles you have to get back. There's always a grant submission that you should be applying for. You know, there's always a job that is on your back, but you do love your work. You can see where your research is impacting your patients when you're on ward service, and that 7-day stretch for me isn't bad because I find every aspect of my job very enjoyable, and it means that I can also have some flexibility to my role, which I couldn't have as a full-time clinician in my hospital.
Yeah, I think flexibility is key, and one of the students asked me, what does my week look like? And it's really never the same. No day's ever the same, is it, let alone a week? Are you laughing because you haven't seen me for 4 weeks, Ross?
Maybe.
Has anyone got any questions for the panel from the floor? Yes.
Hi there, my name's Alex from the University of Sydney. I'm wondering how important is the topic you choose for your PhD, and how much does it influence your research in the future after that?
Well, I have to say my daughter's PhD has nothing to do with anaesthetics. I think it's a good training exercise and it can open doors for you, whatever you end up doing, but I'd be really interested to hear from the panel.
Yeah, I was actually just having this conversation with someone yesterday who's applying for a PhD, and they're really set on their question. And I sort of had a laugh to myself because I remember being the same. I was like, I'd found this researcher working with the Oxford Tropical Medicine Network unit who was doing research that really inspired me, and I'd thought up a question that I hadn't seen answered in the literature and had this beautiful proposal that, of course, was accepted. And I was on my way to starting my PhD, and then within a month I had a new supervisor because of a funding issue, and that new supervisor had a completely different question for me that was on PK/PD, and I was like, that pharmacokinetics is the one part of the physician's exam I just didn't even bother learning because it was so boring. And so I was like devastated and thought, this isn't what I thought I was doing. But in the end, I think the more important thing than a PhD question is who your PhD supervisor is, because for me, what I gained from that 3 years was an incredible network of clinician researchers that I still work with today that inspire me every week. And just being in that realm of those fantastic academics who were doing really clinically relevant research was what mattered, not the question at all.
Rebecca.
Yeah, absolutely agree. It's the process rather than the question. Of course, if you happen to publish within a certain space, that will, be a launching pad if you're going into the more academic side of medicine, and you can sort of show publications and collaborations. But I think as much of a research endeavour, a PhD is also a degree, and it's the process of undergoing the degree.
I think it does help when it comes to networking and the circle of the people you work with, as well as the topics. I don't want to go into the argument about the merits of PhD by publications, but quite a few of the clinicians I work with, medical oncologists, radiation oncologists, as well as surgeons, have actually gained their PhD by publications along the same theme. And I think for someone who's already working, it's an easier approach.
Russell?
Yeah, I often remind the PhD students this is a research training, because often you think this is the end, this is the target, but of course it's kind of the beginning. This is your training in research that then will enable. So you really can do it at a number of different points. And you're right that there are the people who do it, say, early when they're 23, 24, or I started mine when I was 32, and I had already done quite a lot of neurology training, so I had started to think for myself. But they all add value. I mean, the whole point is you're getting this training, and it's helping you think. It's a process in how to think or how to address questions and get answers through methodology.
So I think we're all agreeing that the question's not the be-all and the end-all. However, a point David made earlier in his talk was that if you know what you want to do, it can be very helpful, as Sydney said, to do some research in an area where you're going to get known by the network who may have some influence on your career. Now, any other questions from the audience? Yes.
It's a bit of a gutsy question, sorry, but I was wondering, you all seem to put so much into what you do, which is very inspiring. At the end of the day, what difference are you trying to make, to the world? What kind of legacy do you want to leave?
Who will start on that? Rebecca.
Okay. I mean, ultimately, and mostly, I think people go into medicine because they want to help people. When you sit and listen to all the interview practice for people wanting to go into medicine, I think truly that's what you believe. I think for me, marrying the research with the clinical really helps to optimise the pathway to that goal. And if you can sort of have impact across a population as well as that person in front of you, I think that's the greatest legacy. And for most of us, I think we get our greatest moments with individual patients. We are people, that we go into medicine because we're people. We want to, have interactions as compared to doing basic clinical sciences, or basic benchtop sciences. But I think just that marriage, and so if you can sort of optimise that, then that's the best thing ever.
Phoebe.
Yeah, I think it's, for me, it is that ability to, potentially have population change for clinical conditions that you might find difficult and heartbreaking to treat, or see high morbidity and mortality in your patients from. But I also work, most of my research is in resource-constrained healthcare settings. So at the moment I work with 14 clinical settings across Southeast Asia for my research, and many of those settings 5 years ago didn't really have any systematic surveillance in place for antibiotic resistance, which is the bulk of my research in babies. And in seeing those sites, first of all, come and say, we're really interested in this and we're seeing so many babies die from drug-resistant infections, what can we do? Bring them together as a consortium, building their research skills, and then most of the conferences we're invited to speak at now, I make sure it's one of them that are speaking and presenting the findings, and seeing, being able to build research capacity in more junior people or in settings that normally wouldn't necessarily have that as their priority, for me is a legacy that hopefully will, be something that continues after my grants finish, because you never know when that might be.
Russ.
I got a sort of psychological or philosophical answer, because I think about this. I think we all need purpose. Good medicine gives you purpose. But I guess doing what I do gives me purpose, and it's satisfying. That it's as simple as that. I think we all actually humans need purpose.
Hello, my name is Jordan. I'm from USAID. Sorry, this is a combo question. I guess, what's your recommendation or tips for students or early stage clinicians to find a good supervisor, and vice versa? As supervisors, what do you look for in potential candidates, and what qualities or skill sets are you looking for? Thank you.
Russell, we'll start with you.
Well, ask around. It doesn't have to just be your experience. You can learn from others, because you're only going to have your single experience, but you can listen. And also cut your teeth as well. You can go for the New England Journal paper, but most people cut their teeth on an early research experience, often a case report. And the case report still offers that this is the problem, this is the current understanding, this is what this helps us understand. So yeah, ask around and try it, see if you like it. I remember writing my first paper and loved it. And yeah, sort of didn't look back really.
And we were talking outside earlier about certainly the Sydney students have an MD allocation for research of 15 weeks, is it now? So that's a really good opportunity to see if you like it. Maybe start a master's. If it's going really well, you could consider converting to a PhD. Who else would like to answer this question? Or anyone got anything to add?
I will, I will add to the previous question first, if I may. So that actually changed for me a couple of times throughout my career. So when I first started, I just wanted to have to treat individual patients. But as I went along towards my mid-career, I felt that, when I first started, I just, as a surgeon, I wanted to perform surgery to get rid of the disease. And as time went on, I felt that quality of life of patients becomes so much more important to me. And that's why I've become so passionate about different sequencing in treatment of advanced cutaneous cancers, which is actually my expertise. So when I was younger, it didn't actually bother me that I was cutting out all these lesions and performing reconstruction that in hindsight these days were actually, suboptimal. But these days, as I grow older, I felt that is actually, I personally sometimes would not want that kind of reconstruction on my head and neck area. And I think that, changing the sequence, like neoadjuvant immunotherapy, followed by salvage surgery, only if they absolutely need it, is actually a better approach. So in a way, I'm actually doing research that's going to put me out of my surgical job. But if I actually do the same thing for 30 years, cutting and filling the hole for 30 years, I would have considered that a failure. And sure, it's going to halve my workload. It literally will halve my workload because that's how effective, neoadjuvant immunotherapy will be towards advanced skin cancers. But I have actually found that, it opens up actually new opportunities for me. I've become actually more interested now in like facial palsy surgery, facial rejuvenation, and it actually helps me in other aspects of my work that I've become so much more I actually am so much more demanding when it comes to the aesthetic and functional result, whilst not compromising, oncology. As for the other question, I think it's important to try and figure out as much as you can what field you like to get into. And as David said, look at the track record of the supervisors. And from the other side, from the opposite side, I quite often encourage students to actually come along to my operating theatre, and they do actually scrub in. And the ones that keep persisting and hang around long enough, that eventually they become the students. But otherwise, if it's not their interest, then they self-select in a way.
Okay, so have we got any more questions? Yes.
Hey, I'm Rishi from USyd. So the question I have is in terms of industry collaboration and just the scope of that collaborative effort for, let's say, translational research in Australia versus, let's say, the US or Canada.
Louise might like to make a comment because we're certainly trying to attract fellows to the academy that have a commercial background. And I'll see if the panellists have any response to this first. Russ, would you like to?
Yeah, looks a good question. And you can have an intellectual snobbery about this, which is not healthy. And I think the longer you do this job, you realize there are different areas and you actually need all of them. You need the universities you need the fundamental science, you need clinical, you need public health. But you also need pharma, and you need industry, and you need investment. So it's a far more complex ecosystem, and we should be really respectful of that. Of course, they all have different priorities because they get judged by different things. But that ecosystem is important, and the university has realized you can't just focus on category 1, which is NHMRC. You need philanthropy, you need industry, etc.
And you could put safeguards in place to ensure that there's no adverse sort of influence on your research by industry. Louise.
Yes, Louise Bauer here. I'm the president of the Academy. I just thought I'd briefly comment that our Academy does include people who work in, for example, the drug industry. And in fact, one of the members of our executive, Bronwyn Kingwell, is involved, has a very strong background in that area. And we're very keen to grow that because we need people working at all aspects of health and medical sciences. And that includes both clinical service delivery, population health, but also drug discovery, device development, and so on. But as Russell has alluded, perhaps the broader support and the pathways and the commercialisation pathways for some of that industry is not as well developed in Australia as it is in other countries. I will remind you that there are a range of industries relevant to health and medical research, and that includes like the health departments. Many of us here are actually working, like Liz and, all of the people who are speaking here are all working in both New South Wales Health and in university environments, and juggling that, and that itself is a bit of a challenge. But I think you were talking particularly about pharma devices and things like that, and there's real opportunities there to grow that, and our country needs more investment in those areas and pathways. I think there are many ways. If you do a PhD, it's not that everybody's going to end up becoming the Professor of Cardiology at the University of Sydney. Many people will do PhDs, or maybe they'll do some research, not do a PhD, or they'll do a PhD, but they may end up being really fantastic staff specialists or clinicians who can actually help nurture future people and actually bring an inquiring mind to the care of their patients. All of that is really good. And And some people may end up working in drug discovery work, they may end up working in population health, they may end up working in WHO, in many, many other places, bringing that sort of understanding and that passion for research and evidence to many, many different areas. There's no one pathway that you end up in. But I tell you what, if you're not at all interested in research, then, perhaps, I'm hoping that you will have rethought that. But just because you're interested in research doesn't mean that you can't have many, many different ways that you go. Can I just tell you my own story? I did my PhD in undernutrition in children. I'm now working full-time in the area of obesity. When I was a medical student, I had one-hour lecture during my 6 years as an undergraduate medical student on the topic of obesity, and it wasn't in children. And I've now ended up partly accidentally becoming a public health physician and working globally in advocacy around issues to do with obesity and related areas. Would never have thought about that. And I'm only doing that because I started a PhD that helped me start that process. And I had no idea that I'd end up where I am now when I started, perhaps unlike David, who had much more focus than I did.
David, you didn't talk about commercialisation of any of your research. Do you want to just make a comment?
Venture capitalists are evil. Most people in industry are not. There is a network of physicians in Sydney and Melbourne who have founded successful device and drug companies. We all know each other. If you're really interested, come speak to someone who's been down that path, because there are a few people. Yeah.
And then if you work like me on fetal alcohol spectrum disorder, we don't particularly want to take money from the alcohol industry. Phoebe, developing countries, baby food formulae, there's lots of conflicts, ethical conflicts we have.
Yeah. It is a tricky space, and there is a balance between, utilising funding that may be available and relevant to your research question and ensuring that they're not part of the research design or analysis, and doing the research with what Russell mentioned is Category 1 funding, which is the sort of Australian government funding, which is very, very hard to get. So most of the work that I do is with pharmaceutical companies is actually more in the advocacy space. So next week I'll be speaking to a conference that's very heavily attended by pharma on drug discovery, and I go to say, look how many antibiotics you've licensed for adults in the since the year 2000, which for everyone's information is 40, versus how many for babies, which is 4. And when you then look at the graphs of how many babies are dying of drug-resistant infections every day versus adults, the scale is not comparable. So a lot of the work I do with pharma is actually more in the advocacy space, and I agree that they're often they're great to work with, because they actually do want to try and get new drugs that will save lives, and some will even then engage in programs that enable those drugs to be available in countries that wouldn't necessarily be able to afford them. So that's a lot of the work I do with pharma, but none of it involves taking money at the moment. I'm sure things will potentially change in the future.
Great. Well, look, I'm sure we could continue this discussion for a long time. I haven't got halfway through my list of questions. Thank you very much to all the panellists and to the audience for providing such stimulating questions. We're going to have a break now for something to eat, bit of networking. Put your name down if you want to do some speed mentoring. Spot mentoring, I think Louise called it. And then do come back into this room for the mentoring, and then we'll wrap up after that. Thank you.